All right, so we're gonna go ahead and get started. Let me let these last people in, and then I will let the rest of them in when I'm done with my part. So, people keep coming in. It's gonna keep popping up.
Yep.
All right, so welcome to the AAP classification of periodontal disease update. We are going to go ahead and get started. If you haven't chatted your name and city and state into the chat room, please do that. We're going to be using chat a lot today to communicate. So if you could, we can go ahead and practice that.
Elsa Smith, Estero, Florida.
Hi.
Hi there.
So a little bit about me. I don't like that other slide, so I had to fast forward to just pictures. So my name is Cameron Jones. I graduated from the University of Tennessee in 2009. Go Vols. I'm a big Vols fan. I graduated with my Bachelor of Science in Dental Hygiene. Right after that, I immediately went to work in a private practice. I was there for about a year and a half when I finally decided to join the Aspen team. I was with Aspen clinically for about 6 years when the opportunity to become a hygiene manager presented itself to me. And my husband and I decided to take it, and we ended up moving all the way across the United States from Tennessee to the great state of Washington. And that's where we live now. We haven't looked back. We love it. I was a hygiene manager for about a year and a half when I got promoted to division director of hygiene support, and that is for the West Coast division. And that is where I've been sitting in my role now for over 3 years. I cover Washington, Oregon, Idaho, California, Arizona, New Mexico, and Colorado. So work definitely keeps me busy, but as you can see, I do have a little bit of a life outside of Aspen. Those are my two beautiful girls you see on your screen. They're 4 and 8. We're huge Vols fans, any kind of sports we love, anything outdoor activities, camping, hiking. We're big adventurers. So that's just a little bit about me. And I am co-hosting today with Aileen, and she is going to say hi and introduce herself as well.
Hi, everyone.
Hang on.
Hi, everyone. So my name's Aileen. I graduated from Hygiene College in 2003 in Denver here. So I am a native of Colorado. I worked in private practice for about 4 years after school, and then I was recruited over to a company called Clear Choice Dental Implant Centers. I was with them for about 6.5 years. I hired and trained the hygienists to do prosthetic exams. I helped them scale their company to about 35 centers. And then a little bit later after that, I came to work for Aspen Dental as a division director of hygiene support, kind of like Cameron. I had the Midwest, I had Washington and Oregon, and a couple of the Eastern states. So unfortunately, I had a family crisis. I couldn't travel anymore. So I got on with a company called Renew Anchored Implant Dentures here in Denver. And I was the director of sales and training for them. I had a team of 21 and stayed there for about 4 years. And just recently, I am back with Aspen Dental, super happy to be back on the academic team. So let's see, outside of work, I'm married. I have a grown son and a grandson and 3 great dogs. Other than that, we love the outdoors. We try to take advantage of everything out here in Colorado outdoorsy. So that's about it for me.
Just a few things with housekeeping. You don't have to turn your video on by any means. We typically do this live and in person, so it's definitely different for us virtually. We can't engage you. We can't see your excitement to see us, right? So if you can turn your video on, we're happy for you to. Don't feel obligated. That's perfectly fine. Please mute your microphone when you're not speaking. I really want this to be as interactive as possible. So I do want y'all to speak. I want you to communicate with us, but just double and triple check that your microphone's muted when you're not. So that way we don't get background noises and people aren't distracted by other things. speaking of communication, we're going to be talking a lot of different ways. So first, we're going to do several polls throughout this course. So it'll pop up on your screen. Please know that every answer is completely anonymous. It's not going to show who chose what. It's not going to show us who chose it. So please just give your best educated guess, and it'll just show us the percentage of who answered what. So no worries there. We'll also, there's, as many of y'all have used already, you can unmute yourself. It's the shape of a little microphone, and you can just ask us questions or comments that you may have. There is also the chat box. The chat box we have definitely been using already, and we practiced that at the beginning. So please, Aileen and I will keep an eye on that. So definitely you can do your chat box. And then also there's a raise your hand button that looks sort of like a hand. Y'all can do that as well. So lots of different ways for us to communicate. Again, I want it to be as interactive and as fun as possible. So please feel free to use that. If you must step away, it's fine. You don't have to worry about that. And we're going to go pretty fast. So I know it's Friday afternoon down in Florida. You are ready to get your weekend kicked off. So we're going to move pretty quickly. But if you need us to repeat something, slow down, provide clarity to something, please, please, please don't be afraid to ask. There's tons of people on this call, over 70 people right now. So if you have a question about something, I guarantee 5 other people on this call probably have the same exact question. So just ask it. And if we don't know the answer, we'll find it out for you. So your sponsor today for the CE course is Aspen Dental Management Incorporated. We've been very blessed. They let us provide this course to everyone. Aileen and I are very thankful that they asked us to present this course for y'all. So that being said, ADMI is who your CE certificate is going to come from. You can expect that certificate in about 60 days from the completion of today's course. So what happens is you take a course evaluation at the end of today, submit that, and then about 60 days, you'll get your CE certificate to the email address that you registered with. You might want to write this email address down or take a quick screenshot of it, because if you have any issues getting your CE certificate, if it doesn't come, the CDE at Aspen.
It lets me listen, but there's no pictures. There's nothing on it.
What did you say? Tammy, I think.
It's Camille.
Did somebody have a
Can
question?
you hear me? I can't see anything.
Did you join by like the Zoom app on your phone or the computer, or
A Zoom app on my phone. I've signed it 3 times and it just comes up blank. There's nothing here.
I
can hear you. I can't see anything.
Can everybody else see everything okay, or does anybody else have any issues?
I am too. I can't see you.
Did y'all call by the actual Zoom link and not the phone number? If you do by the phone number, it won't show anything.
No, I came in by the link that y'all sent me.
Maybe if y'all reach out to your hygiene managers via text, they might be able to help you.
Thank you.
Let's see, a lot of people saying they're good in the chat.
Yeah. Yep.
I'm seeing if anybody's going to help you. Hopefully somebody can get her to where she can see just fine. So that's about it about ADMI. If you have any questions or you need your CE certificate ahead of time, please just email cde@aspendental.com and they'll try and get that out for you as well. So about the learning objectives for the course. So the basic key core concepts are what we want you to take away. We're going to break it down and give you some key questions to ask yourself before somebody's using annotate that's drawing all over the thing with their mouse. So if you have the annotate button, just try to exit off. But yeah, somebody's drawing all over it. But if you could, so we're going back to the key core concepts. We want you to take away those. So some of you, this is probably your first course you've ever taken. Other of you, this is probably a great refresher course. You know a ton about staging and grading. And then a lot of you probably fall somewhere in the middle. So it's going to be different learning for everybody, but we definitely want you to know those steps so you can take it back to your offices and to your patients and get an accurate stage, grade, and distribution for each patient. Speaking of that, we are going to take a quick poll right now. And it is going to say, how much learning have you done around the new 2017 update? So this is going to help Aileen and I cater this course to y'all today. Again, remember, just look at your phone, your screen, and you can punch in the numbers or punch in your answer. Completely anonymous. Nobody is going to see this. It's just going to give us a percentage of what everybody answered. So how much learning have you done around the new update? We're just going to give everybody a minute, or not even a minute, a few seconds more to answer. All right, so hopefully everybody can see those results on your screen. It's pretty widespread. A refresher course for me, I know them well. I haven't taken a course, but I've done some research of my own. So a lot of you have definitely the basic knowledge around it. So that'll make things go a little smoother for us, for sure. Aileen's going to take it away and launch us into the course.
Excellent. All right, so let's get started, everyone. So this, what you're looking at here on the screen, is just a snippet of the Journal of Periodontology. It was published back in 2017. Basically, the European Federation of Periodontology and the American Academy of Periodontology, they came together in Chicago for a world workshop. There were like 100 experts on perio there. And what they did was they changed the way that we define, the way that we document, and the way that we diagnose periodontal disease. It had been since 1999 since these two organizations had come together for this update for these classifications. So it's been like 18 years. So with all the new research that they did and all their new knowledge, they came together to change the way that we define, the way that we document, and the way that we diagnose periodontal disease, but not the way that we treat periodontal disease. So I'm just going to say that one more time. They came together to change the way that we define, the way that we document, and the way that we diagnose periodontal disease, but not the way that we treat it. So we're still treating it the same way that we always have, with scaling and root planing, with periodontal surgeries, lasers, things like that. Okay. All right, let's take a quick poll here. We just kind of want to get your pulse on this. So Cameron, would you launch the next poll? We just want to know what percent of the US population has periodontal disease? There's no right or wrong answer here. We just kind of getting a pulse on what everybody thinks from the 1999 classification.
And while everybody's taking this poll, if y'all could please double and triple check that you're muted so we don't get a lot of background noise, okay?
Okay, so some of you said 47, some 64%, and most of you said 75%. So let's go to the next screen and see what they say. So for those of you who checked 75%, you are 100% accurate according to the 1999 classification, the guidelines. So remember back in 1999 when gingivitis was lumped in with the periodontal disease bucket? Well, now it's in a bucket all on its own. And that bucket is called gingival health and disease. So periodontal disease is now in its own bucket just as well. So with that being said, 47%, almost half of Americans have periodontal disease. And I love this graph here because it's still like in alignment with the 2017 update, and it has huge impactful information for us all. Basically, they're telling us that 65 million Americans, they still have periodontal disease, and they need our help to get them back to healthy. So what do we need to know as clinicians? We need to get better at identifying and diagnosing periodontal disease as early as possible. So right here, I want you guys to unmute yourselves, or you can chat in, however you want to do it, but tell us why you think that these experts got together and they want us to identify, to diagnose, and to treat as early as possible. Any ideas out there? Any thoughts on this? I'm looking at the chat box to see if any of you are chatting in. We got save teeth, systemic health, great answers, prevention. Any others? To avoid loss of periodontal tissue. These are great answers. And I love the because of correlation with systemic health. That's right. Early diagnosis. You guys have all kinds of answers. That's great because there's a lot of reasons why they want us to identify and diagnose and treat as early as possible, right? You know that those systemic health and the oral health correlations are huge. They're very important for all of us and all of our patients. So if any of you went to school like 10 years ago or so, like I did, you would remember, like if you had a patient with a 5mm pocket on the upper right quadrant, they were, you went to the doctor, you talked about this 5mm pocket, the patient was pretty healthy, they had good home care. So you and the doc said, you know what, we're just going to watch this. It's okay. We'll check it when they come back in 6 months for their cleaning. Well, they came back in 6 months for their cleaning and we watched it all right. But what did we watch it do? We watched it get worse, right? It definitely didn't get any better. We know that. So that's why they're saying that we need to start identifying and treating it a little bit more aggressively than we used to. The thought is here that the intervention at an early state will save the patient from a lifetime of disease management and possibly, like what you just talked about, some systemic complications, right? So let's try to be more proactive and not reactive as clinicians. I think that this should be, and so do they think that this should be the direction of our profession. All right, so let's take a look at this. We're just gonna compare these two classifications here. Let's look at the 1999 classification. It's based almost entirely on the severity of past destruction. Whereas the 2017 classification, yes, it's based on severity of past destruction, but as you can see, there's a lot more things that they're considering here now that they want us to consider. So for instance, does this patient have missing teeth due to periodontal disease? How complex is it going to be for us to manage this patient's treatment? And then also, what's the likelihood of this patient's outcome to their treatment? So you can see now that there's a lot more to consider now when we're talking about periodontal disease. So we just want to get a more accurate prognosis for our patients. So a lot of things to consider. All right. So here it is. This is the 2017 AAP classifications of periodontal disease and health. You can see that they've put them into 3 different buckets. The first bucket is periodontal health and gingival disease. And under that bucket, we have healthy, we have gingivitis that's caused by biofilm, and then we have gingivitis that's not caused by biofilm. So let's do another fun poll right here, okay? So you guys can chat in, or if you want to unmute yourselves. But the question to all of you is, what are some of the examples of gingivitis that is not caused by biofilm? Let's see what your answer is here. Just a few more seconds. All right, 93% of you said all of the above. That's great. There's a lot of reasons why gingivitis is not caused by biofilm. So good job, everybody. Okay, so let's get back to the second bucket here, which is periodontitis. We have stage 1, which is mild, stage 2, which is moderate, and stage 3, which is severe with potential for tooth loss, and stage 4, also severe with potential for dentition loss. So you can see here that stage 3 and stage 4, they're both severe. Now there's going to be some differences here, and we're going to talk about that here shortly, okay? But let's move on over to the third bucket. The third bucket is peri-implant diseases and conditions. So under that bucket, we have peri-implant health, peri-implant mucositis, peri-implantitis, and peri-implant soft and hard tissue deficiencies. But for our purposes today, we're going to focus on bucket number 2, which is periodontitis. And that's because this is where most of the changes of the update were made. And plus, this is where we stage and grade from. Okay, so there are 3 steps to staging and grading periodontitis. First, there is to staging. Second is grading. And third is listed distribution. So we're going to go ahead and take a deep dive now into staging.
Before we move on, everybody, please just double check, make sure you're muted because they were definitely getting a lot of background noise.
Okay. All right. So with staging, this is something I want you guys to take away. So you might want to write this down or just remember it's a huge takeaway from this course is that when you're staging, you're always going to stage from the worst site of clinical attachment loss in the mouth. Okay. If you don't know this because you don't have a perio chart, then you're going to stage from the worst site of radiographic bone loss. So let's just say that, let's just first go through this chart. Stage 1 is mild periodontitis. Stage 2 is moderate periodontitis. Stage 3 is severe periodontitis with potential for tooth loss. And stage 4 is severe periodontitis with potential for dentition loss. So we're going to go ahead and narrow down our choices right here. Okay, so what we're going to do is we're going to break this into 2. You can see by that line right there in the middle, we're going to break this into 2 different groups. So the next thing you would ask yourself is, there's going to be 2 questions. These 2 questions are important. So the first question you ask yourself is, does this patient have missing teeth due to periodontal disease? If the answer is no, then they're going to most likely be a stage 1 or stage 2. If the answer to that question is yes, then they're most likely going to be a stage 3 or a stage 4. But what if we have no idea how they've lost their teeth, right? Maybe they had lots of decay and they didn't want to go through a bunch of root canals and crowns, things like that. So sometimes we just don't know how people lost their teeth, right? So when we don't know that, that's when we're going to go to the number 2 question, which is, what is the percentage of radiographic bone loss at the worst site? So if the percentage of bone loss radiographically is less than 33%, it's going to be a stage 1 or a stage 2. If the radiographic bone loss percentage is greater than 33%, it's going to be a stage 3 or a stage 4. Okay, so now that we've broke that down just a little bit more, we're going to go ahead and take a deeper dive now into the stages. So let's take a look at stage 1 and stage 2. Stage 1 is your mild periodontal patient, and stage 2 is your moderate periodontal patient, okay? You can see here that there's a lot of similarities. We have redness, swelling, bleeding upon probing. There's no missing teeth. There's no mobility, no furcation involvements, and mostly you're going to see horizontal bone loss here. So what are the differences, right? This is where they really made a more aggressive update to staging. So stage 1, you have pocketing of 4 millimeters or less now, and radiographic bone loss less than 15%. So back in the day, you wouldn't scale a periodontal pocket if it wasn't a 5 millimeter. Now they're asking at 4 millimeters so that we can keep up and get ahead of the disease. Stage 2, you're moderate, you're looking at pocket depths of 5 millimeters or less and radiographic bone loss anywhere between 15 and 33%. All right, let's look at stage 3 and stage 4 now. Same thing here, a lot of the same similarities. There's redness, swelling, bleeding upon probing. Now this time we're having possible mobility, possible furcation involvement, and possible vertical bone loss. So what's the difference here? Let's look at the difference. Stage 3 is, we're asking ourselves now about missing teeth, aren't we? So stage 3 is 4 or less missing teeth, whereas stage 4 is 5 or more missing teeth. I want you guys to think about stage 4 as like your denture patients. These are the patients that, you know, they don't have hardly a jawline anymore, right? They have severe ridge defects. Maybe you have drifting teeth, flaring teeth. You've seen those patients with bite collapse, right? So these are your masticatory dysfunction patients. So think of them as your denture patients. Okay, so let's just talk a little bit more about clinical attachment loss. So clinical attachment loss is from the CEJ of the tooth to the base of the pocket. This gets confusing for people sometimes. So the CEJ is from the base of the tooth to, or I'm sorry, the CEJ of the tooth to the base of the pocket, whereas the pocket depth is a gingival margin to the base of the pocket. So when you have a patient with recession, you're looking at recession plus the pocket depth will equal your clinical attachment loss. Is there any questions on clinical attachment loss? Nope. Okay, great. All right, so let's take a look at this chart. This is a really nice chart. This came straight off of the AAP website. We recommend that you all go to the website, print this off, laminate it, take it back to your practices. This is a great cheat sheet for you. We basically just want everyone to get out of the mindset of that old 1999 classification scenario. So what I want you to get off of this chart here is to look at severity and complexity. Complexity is the one in the dark gray. So the takeaway from this slide is that complexity always trumps severity, okay? So let's do a couple of little examples here. Let's say you have a patient here who has 10% bone loss. All right, so they're in a stage 1 category, aren't they? But you look at their perio chart, they have 5 millimeters clinical attachment loss. So where does that put them now? Now they're in a stage 2, aren't they? That's because complexity trumped severity. Let's do one more example here on this. So let's pretend we have a patient and they have 25% radiographic bone loss. That puts them where? Stage 2, right? But when you look at their perio chart, they have 6+ clinical attachment loss. So now that puts them into a stage 3. Once again, complexity trumps severity. Okay, great. So this is just a review on staging. Let's make sure you guys understood all about staging, but first we're going to take a poll to see what you did learn. The question is, what side in the mouth do you stage from? Let's see if you remember what we talked about earlier. What side in the mouth do you stage from?
Can I ask a question while the poll's going?
Sure.
So for stage 3, is it the pocketing is 6 millimeters or more? Like the actual probing depth?
For under complexity for stage 3, yeah, it's 6 millimeters or more. Mhm.
Okay.
Did that answer your question?
Yes, I'm just reconsidering all the patients that I saw with 6 millimeter pockets that I put in moderate.
Right.
Don't worry,
and
we
that's-
all do that. It's a lot more aggressive. It's a lot, I mean, 4 millimeters or less is your stage 1, which is less than 15%. So it's a lot more aggressive. So don't worry, we're all in the same boat, Kelly. Don't be
Exactly.
Had a small panic attack.
We're getting ahead of the disease now instead of trailing behind. All right, so the poll says 49% of you said site of the worst clinical attachment loss. Great job. So that is, we always stage from the greatest site of clinical attachment loss in the mouth, right? If we don't know where that is though, we ask ourselves 2 questions. Does anybody know, you can unmute yourselves or chat in, does anybody know what is the next question we would ask ourselves? If we don't know, and we don't have a perio chart, we've never seen this patient, we don't know what the worst side of clinical attachment loss is in their mouth, what's the next thing we ask ourselves? There was 2 questions we talked about earlier. What's the first one? So it said x-rays, bone loss and x-ray.
bone loss and x-ray, missing teeth, worst site of radiographic bone loss.
Great. So the first question we ask ourselves is, does this patient have missing teeth due to periodontal disease? If the answer to that question is no, then they're most likely a stage 1 or stage 2. And then if the answer to that question is yes, then they're most likely a stage 3 or stage 4. But once again, what if we have no idea how this patient lost their teeth? Then we ask the second question, which is, we had some answers here. The worst site of radiographic, the percentage of bone loss, of radiographic bone loss, right, at the worst site. That's the second question we ask ourselves. And if that's the case, if it's less than 33%, we're looking at most likely stage 1 or stage 2. And if it's greater than 33%, it's most likely going to be a stage 3 or a stage 4. Okay. Any questions on staging before we move on?
I have a question. It's not regarding staging. As far as I'm not basing my diagnosis as far as insurance is concerned, but is insurance going to be following this as well?
There should be. There's a lot of meetings going on right now with insurances for the yearly updates for next year. But you know, even though if we're staging them more aggressively and treating them more aggressively, the key that they're going to look at is they have to have that slight radiographic bone loss. So you'll hear me talk about it in the end of this course as well, is that I think this is a really good time to address our teams that we need clinically excellent x-rays. They need to be clear and where, you know, they can see everything that they need so they don't balk on paying us or reimbursing us for these. You know, they reimburse us based on what the documentation we present.
Okay, yeah, I just want to make sure. I'm not basing it on insurance's purposes. I'm just making sure that, you know, when we have clear documentation and all that, that they don't give us any kickback or anything.
You know,
like
they always find reasons to, but I really hope not. Yeah. So no, it's a valid question. Good, we get it a lot. So
it is. It's a very valid question, and I think, you know, Cameron hit it on the head. Is make sure that we're doing the best thing to document, send all the information that the insurance companies need.
Okay, thank you so much.
You bet. Okay, so any other questions on staging before we move on? I'm sorry, hold on one second, Cameron. There's a question. What if the teeth are currently in the mouth, but we'll need, hold on, let me just read this real quick. Cameron, are you reading that question from Amanda?
What if the teeth are currently in the mouth but need to be extracted due to perio? So it's not just the teeth missing due to the perio, it's also the risk of loss as well. So you're right, you do consider that when you're staging. Absolutely. Good question.
Question, Amanda. Okay, so we have 3 steps to staging and grading periodontitis. We just went through staging, and now we're going to move into grading your patient. And then we'll get into distribution after that. Before we go into grading though, I want to ask all of you a question. You can unmute yourselves or chat in. Why do you think that these experts all came together and changed the verbiage to staging? Stage 1, stage 2, stage 3, stage 4, instead of the old terminology of mild, moderate, severe. Why do you think that they did that? Any ideas?
I think that they did it because they were trying to make a language that the patients would understand better. And with other diseases like cancer, they have stages. So they feel like maybe patients get that.
That's excellent. Excellent answer. Yes, I believe that's true. You know, like cancer is a great example of that. So if you have a friend that calls you one day and says, you know, I have stage 1 cancer, you know, it's horrifying, it's sad, but you know, you hear the word stage 1 and you say, you know what, it's a possibility, this is okay, we're going to get through this. The treatment's going to be less aggressive. The patient will probably have a great outcome, right? But if you have someone who calls you, a friend that calls you and they say I have stage 4 cancer, then now you're, you know, that kind of hits you a little harder, doesn't it? Because now, you know, this is more severe and the treatment's going to be much more aggressive and the outcome of the patient's treatment may be poor. So I think you're right. I think that, you know, they're trying to get the patients to hear the stages and define the severity of the disease, just like cancer. So that's a great answer. All right. Thank you, guys. Okay, so now we're going to move on to grading. I'm going to turn it over to Cameron.
So when you're grading your patients, you're actually defining the rate of progression of disease and the patient's likely response to the treatment or the prognosis of the treatment. So when you're grading patients, you have 3 choices. You have grade A, grade B, and grade C. Grade A is your slow rate of progression of disease and a pretty great or pretty good prognosis of the treatment. Grade B is your average rate or progression of the disease, and the prognosis of the treatment is pretty fair. And then you have grade C, and grade C is your aggressive rate of progression of the disease. And the prognosis of the treatment, although typically poor, it's very guarded because this patient probably has a lot going on, a lot of things, health habits, conditions, medications that can really affect the outcome of our treatment. So we're really not sure how this patient might react or what their prognosis may be. So there's the 3 choices. And seeing as how I'm telling you, you have 3 choices for grading, you're probably wondering why I'm sitting here with grade B just sitting on your screen. And there's a logical explanation for that. So the AAP states that 80% of your patients will be a grade B. 80% of your patients will be a grade B. Wouldn't we have all liked that likelihood when we were taking our hygiene boards? 80% chance choose B, you'll get it right, right? We didn't have that likelihood then, but we do now. So when in doubt, choose B for your patients. The AAP states that actually you should probably start at B, evaluate your patient, and then decide if you need to deviate from there to A or C. So we're going to dive a little bit deeper into all the grades. So first we have your grade A patient. Grade A has no bone loss over 5 years. They have heavy biofilm deposits, but pretty low levels of destruction, you know, nothing too bad. This is your unicorn patient though, because they have no tobacco, no health habits, no systemic conditions. They are the epitome of health. And if you think about people, you know, I don't really know many people that fit in this category. Maybe Caitlin, y'all's director, she's pretty healthy, but that's about all I can think of. So your grade A is your unicorn patient. And then we have grade B. And grade B, remember, is your average patient. So they have less than 2 millimeters of bone loss over 5 years. The destruction is pretty proportionate with the biofilm deposits that you see. They may have some health habits. They may have some systemic conditions. Maybe their health habits are like they're a social drinker or smoker. Controlled systemic conditions would be like maybe they have high blood pressure, but they control it with medicine. They have depression, controlled with medicine. They have diabetes, controlled with insulin, things like that, and diet. So they might have things going on, but it's very controlled. So that's your grade B. And then we have grade C. And grade C is over 2 millimeters of bone loss over 5 years. Destruction just exceed your expectations. You look at that and you're like, whoa, I did not expect this to be going on. They have excessive tobacco or other health habits, uncontrolled systemic conditions. They got a lot going on. Excessive, according to the AAP, though, I do want y'all to know, if they smoke 10 or more cigarettes a day, that's excessive tobacco to them. So, and I agree with that. So excessive tobacco is 10 or more cigarettes a day. If you're looking at the screen, you can probably tell that there is some math on here too. So if any of you are math lovers out there, I'm not in that club, but if any of you are math lovers out there, there is the math equation. So when you take the percent of bone loss, and this percent of bone loss is at that worst site of clinical attachment loss. So that site, what percent of bone loss is in that site, and divide it by the patient's age. I'll give you an example. So we have Caitlin, she's your director, and she's 50 years old. She looks amazing, I know, but she's 50 years old. And at her worst site of clinical attachment loss, she has 50% bone loss. So it's wow, it's pretty alarming, but 50% divided by 50. So you take 50 divided by 50, and that gives you 1. So she would barely squeak by into this grade B category, okay? So using that mathematical equation, it's the percent bone loss at that worst site divided by the patient's age. All those math lovers out there, you're welcome. That's a good way to do it. So again, this is just a reminder, when in doubt, choose B. We're going to just talk about breaking down grading just a little bit more on what we're looking at. So we have the direct evidence, and y'all heard me talk about that. Direct evidence is just bone loss over time. A lot of times we don't know that, right? This is the first time we're ever seeing the patient. Who really measures like the actual bone levels from year to year to year? Maybe some, you might have some cool computer equipment that does that, but we don't really know the bone loss over time. So we can't look at that too heavily. So then we have the indirect evidence. So indirect evidence uses that mathematical equation I just talked about, the bone loss compared to the patient's age. And then also it uses our critical thinking skills as clinicians. So is the destruction proportionate with the deposit? So what you're looking at, is that what you expect to see? Then we have the grade modifiers, and this can really affect grading. And this is something as clinicians we really need to pay attention to. These are really important. So your grade modifiers are your health habits, the systemic conditions, the medications. So all this health realm of things that we got to look at for our patients. We got to be really diligent about looking into their health history, asking for updates, and using our critical thinking skills. So if the patient tells you their diabetes is really controlled, but then they come into your operatory eating white powdered donuts and a big gulp Mountain Dew, you can probably use our critical thinking skills and be like, probably not controlled. They're probably going to be a grade C. So little things like that is what you want to look at when you're grading. Anything that can really affect the prognosis of the treatment and the outcome of the treatment. So we're going to do a quick review on grading, but first we're going to do a quick poll. I'm going to get it pulled up here. So what grade does the AAP state that 80% of your patients will be? I said, when in doubt, choose this answer. You definitely want to know this. I'm done. I think I can go home. Y'all all got it right. So,
Great
80%,
job.
when in doubt, choose B. So definitely y'all did a great job with that. So we're going to recap grading. So remember, grade B is 80% of your patients. We can always use that mathematical equation of the bone loss over divided by the patient's age. If we use that, then they're going to fall between a 0.25 and a 1 for grade B. That's your average patient. You know, everything's pretty average with this patient. Destruction's pretty proportionate with the biofilm deposits, tobacco, health habits, controlled systemic conditions. They might have a little bit going on, but everything's very light, very controlled. That's your grade B patient. Then we have grade A. Remember, grade A is your slow rate of progression of the disease, and the prognosis is good. So again, if we use that mathematical equation, they're going to fall less than a 0.25 would be your answer. They might have heavy biofilm deposits, but the destruction's very low. And again, always think of grade A as your unicorn patient, the epitome of health. Rarely going to see a grade A patient, to be honest. So I think the AAP states about 5% of your patients will be a grade A. And then we have grade C. And grade C, remember, is your aggressive rate of progression, and the prognosis is pretty poor or guarded due to a lot of things going on. If we use that mathematical equation, then the answer is going to be greater than a 1. Destruction exceeds your expectations, excessive tobacco or health habits that they're using, and they have uncontrolled systemic conditions. So a lot going on with this patient. Any questions at all on grading?
Cameron, there is some funny chat going on that I want to bring up. So someone asked if, and then we're getting lots of different answers from everyone, and it's getting kind of funny here. So I wanted you to clarify, can we ever change the stage and the grade if the condition changes or improves?
Yeah, absolutely. So they said actually a lot of times the stage can only get worse because it can't really go backwards because the bone loss doesn't really ever come back. So that is a little harder. I'm sure it can happen, but it'll be a rarity. So if stage moves, a lot of times it's moving in the worst direction. Grading, I think, can definitely change because health habits change, conditions change. So I think grading, again, 80% of them are going to be B. That's going to be nice for everybody. And with our patient base, it actually, you might see a little bit more C because our patient base is a little different. But yeah, absolutely, things can change.
Great, thank you.
Any other questions on grading?
When are we scaling 4mm pockets with minimal bone loss?
If they have bone loss and it's 4mm pockets, we should be scaling them every time. That's part of this update. They said they want it aggressively and as early as possible because we're doing our patients a disservice. The earlier we can get them to healthy, the better. And we know if we come at them at all angles and aggressive as we can, then the faster they'll get to healthy. Doesn't matter if they smoke or not. Absolutely. To be grade B, no, but if they can smoke some to be a grade B, think of like, just a few cigarettes a day or a social smoker, but they cannot do it more than 10 cigarettes a day. If not, they're a C. Yep, if they smoke a pack of cigarettes a day. So the question was, is a patient with a perio who smokes a pack of cigarettes a day automatic C? Absolutely. You see that, boom, they're a C. Makes it easy. Those grade modifiers really can swing it. So that's what you're definitely going to look out for, are their health habits, their conditions, is it controlled, things like that, their medications. Good questions. Any other questions before we go on? And don't worry, we're going to put these into practice, guys. So, all right. So there's 3 steps to staging and grading. Aileen talked about staging, I talked about grading, and now Aileen is going to take us into distribution. So we stage, we grade, and then we list a distribution.
Distribution is easy, guys. This is the easy part of all of this. So there's only 3 steps to distribution, 3 answers to distribution. So localized is less than 30% of the dentition is affected. Generalized is 30% or more of the dentition is affected, and molar incisor, which is rarely used. That's where only the first molars and all the incisors are affected. That used to be called juvenile periodontitis. Now it's called molar incisor. So distribution's pretty easy there. Is there any questions on distribution? Okay, so there's 3 steps to staging and grading periodontitis, right? Establish a stage, determine a grade, define a distribution, and add it as a description. So just use it just like that. Okay, we're going to go into some hygiene cases here. This is where it's going to get interactive. You guys get to help us. So we're going to do an example first. Cameron will do an example, and then we'll start with our first case step, or case 1 that you guys can start helping us with.
So again, like Aileen said, this is going to be the interactive part. I'm going to ask some questions. We're going to have some talking. So have your chat box pulled up. You can unmute, anything like that. But we're going to walk through a couple patients. I'm going to help you a lot on this first one. And then as you notice, as we go on, we're going to do 4 together. We'll help you a little less each time. So here is Alex. Alex is easy on the eyes. So this, anybody Grey's Anatomy fans out there, he is McDreamy. So I'm a big Grey's Anatomy fan, so we had to have him in here. So we have McDreamy here. And unfortunately, McDreamy is not as McDreamy as we thought he was. He's a 50-year-old construction worker, and he has breath so bad that his wife forced him to go into the dentist. We've all seen these patients, right? So he has tons of health conditions going on. He's taking lots of medications. He reports smoking a pack of cigarettes a day for 35 years. He also must live out here where I do in the Pacific Northwest because he vapes cannabis every day. And he drinks 3 to 5 alcoholic beverages a day. So he has a lot going on. He hasn't been to the dentist in over 10 years, and he does have a past history of tooth loss. So before I move on from this slide, we just talked a lot about staging and grading and things to look for. So what are some things that really stand out that we'll definitely need to consider when we're staging and grading Alex here?
Pack of cigarettes a day.
Absolutely. So Kelly, stay unmuted for me. What about that pack of cigarettes a day? What's that going to mean for us when we're staging and grading?
He's going to be a grade C.
Absolutely. That's a grade modifier. And we know if they smoke 10 or more cigarettes a day, anybody know how many's in a pack? Because I truly don't know. Is it like 24? 20. There you go. So 20. So we know he definitely belongs in grade C because of that. Awesome. Thank you, Kelly. And I think, are you looking at the chat, Aileen? It's blown up, so.
No.
What else? What else stands out? They're saying he's grade C, that he has a history of
Tooth loss and tobacco.
Absolutely. Medications, yeah. Tons of medications, right? So those are definitely.
There's tooth loss.
Absolutely, tooth loss. That's something we consider when we
Stage.
Absolutely. So
Correct.
we are going to move on. Let me. All right. So some of his health behaviors. So he brushes a time a day, uses mouthwash for his bad breath. That obviously didn't help too much because his wife sent him in. He has some calculus. Instead of going over this, I'm going to show y'all his intraoral pictures. There's his pictures, a lot of staining you can see due to all that smoking he did, vaping, tartar. He obviously went not to an Aspen because they have film radiographs. So, you know, let's say we didn't have the perio chart, we'd be looking for that worst side of of radiographic bone loss, right? If we didn't know clinical attachment loss. So to me, I would say I feel like this is probably that worst site. I don't know if anybody else can see it. I feel like it's barely hanging in there. And this is where, you know, things can definitely get subjective because I'm going to guess it's probably like 90% bone loss. Somebody else may guess 85. Somebody else may guess 75. You know, like we all are subject to our own opinion here. So to me, if I didn't know clinical attachment loss, that's what I would guess is the worst site. So, but we do know clinical attachment loss because we have their perio chart here. So remember, the first thing we want to do when we're staging is we're looking for the worst site of clinical attachment loss. So go to that clinical attachment loss line and find the worst site. I can't see all of it. I believe it's here, 757. and then we narrow down our choices. We ask ourselves 2 questions. Is this patient probably missing any teeth due to perio? You got the chat, Aileen? Are you looking at the chat?
Yes, I am. We're getting lots of answers. Grade C, stage 4, grade C. And then someone said, Geraldine said at site 25 and 26, she's feeling that's where the clinical
Yep, I
attachment
agree.
loss is.
That's
So
the
that's
worst side of
correct. I
it. Yep.
agree too.
So yes, I would guess, to me personally as a clinician, I would say, yep, he's missing teeth due to perio. So that would automatically narrow my choices down to stage 3 and stage 4. If we remember stage 3 and stage 4, they're both severe perio, right? But it's severe with potential for tooth loss and severe with potential for dentition loss. So again, we're gonna just things for you to think about. But we're gonna do a quick poll, and we're gonna have everybody do their opinion of stage, grade, and distribution for Alex. Again, completely anonymous. Nobody is going to see your answer, but what do y'all think he is? And we're gonna give it some time. Everybody needs time to think.
Getting some really good answers on the chat, Cameron.
Okay, just a few more seconds to lock in your polling vote on the stage, grade, and distribution for Alex. And it is a tight race. We're gonna have some good discussion. All right, so literally it was like a split: stage 3, grade C generalized, and stage 4, grade C generalized. The correct answer is stage 4, grade C generalized. And the reason for that, can anybody tell me why he's a stage 4 actually, before, instead of me giving you the answer? Why would we stage 4 over stage 3? Can anybody remember the differences in the 2 stages? Anybody? Nope. So stage 3 was 4 or less missing teeth due to perio, right? And stage 4 was 5 or greater. To me, or risk of loss due to perio. I think he's risk of losing a lot, and he's already missing more than 4. So to me, that automatically puts him in that stage 4, and he's definitely generalized, and he's grade C because that's a pack of cigarettes a day. So that's how we got stage 4, grade C, generalized. Yeah, and everybody in the chat was right. Absolutely. All right. So we're going to do the next one, and we have Sally here. Go for it, Aileen.
Okay, so let's look at Sally's case. She's 29. She's never had her teeth cleaned because she doesn't like going to the dentist. She's anxious about it. Her gums bleed. She has sensitivity. She doesn't like to smile. Her mouth is always dry. Her medical history, she's not really under the care of a physician, but the only thing she takes are vitamins and antihistamines daily. She hasn't been to the dentist, she says, over 3 years ago. And the only reason she went was because she had some pain around her wisdom teeth. Let's take a look at her dental and health behaviors. She's brushing once a day with a hard brush. She never flosses, but she mixes warm water with mouthwash. She once again is complaining still of all the pain in her lower molars. And recently, though, she started smoking 1 pack of cigarettes a day, and she's drinking energy drinks at least once a day. She has a moderate buildup, generalized. Let's take a look at her intraoral pictures. So what do you all see here? Take a look at her tissues, buildup. And let's take a look at her radiographs. Take a nice good look, things that we've just talked about. Missing teeth, clinical attachment loss. I know that you're all looking at that calculus and those molars. You're probably all wanting to get your instruments out and clean that calculus out of there, aren't you? I know that I am. Okay. So let's take a look at her perio chart. Take a nice long look at it, see what take a good look at what you need to be looking at for staging, grading, and distribution. We have some good answers coming in on the chat. We're going to do another poll here. Give you just a minute to take a good look. We're already getting guesses, Cameron. Okay, so here's the poll. What is the stage, the grade, and the distribution for Sally?
Everybody's pretty
Yeah.
loud. This one.
Yeah, good. It's great.
Just a few more seconds for everybody to lock in their vote for Sally, stage, grade, and distribution.
Excellent. Most of you chose stage 3, grade C, generalized. Just a few of you on the stage 3, grade B. So excellent job. That's correct. Sally is a stage 3. She's a grade C and generalized, right? It's affecting more than 30% of her teeth.
What about, I think the difference was the grade B and grade C. So somebody who chose grade C, tell them why we chose a grade C. Somebody's answering in the chat.
Cigarettes, tobacco use.
Yep, that was a key thing that we had to pick up on, right? That she smoked a pack a day.
Excessive smoking, that's correct. Cigarettes.
Yeah.
Change the grade of Sally.
Yep, that's a grade modifier that swings it to one way. So absolutely. All right, so next we have Billy. Billy is a 50-year-old truck driver going through a divorce. His breath smells bad. He has difficulty chewing. His lower teeth feels like they're mobile. He has high blood pressure, mood disorder, and anxiety, but he's taking a daily medication to control his blood pressure and antidepressant for his other conditions. So that is something you definitely need to take into consideration. So some of his dental behaviors, he has trouble brushing due to his job. He's a truck driver, always on the road. He eats on the run, drinks 4 to 5 cups of coffee a day with sugar. He consumes several sodas a day. He does not get regular sleep and feels overall fatigued. Here again are the film radiographs that old Billy got taken. So again, if we didn't know the clinical attachment loss, we would be looking for the worst side of radiographic bone loss. Lucky for us, we have pictures and a full perio chart. And again, this is a great time for me to mention, it's really, really important for us as hygienists to make sure we accurately chart everything. So for accurate clinical attachment loss, we need pocket depth, we need recession, we need furcation involvements. That way we have everything we need to accurately stage and grade our patients. So just making sure we're doing those full, complete perio charts. So again, take a look at Billy and you remember how you start staging. You find the worst side of clinical attachment loss. You ask yourself 2 questions and then you break it down from there. I'm just gonna give you a little time. All right, so I'm going to do the poll for Billy. So we're going to stage, grade, and distribute Billy. So just a few more seconds, about 10 or 15 more seconds to lock in your vote. All right. So we have 58% say stage 3, grade B, generalized, which is definitely what we have decided he is as well, stage 3, grade B, generalized. So for those of you that said grade C, the reason, why did we put him as a grade B? Can anyone tell everybody why we chose grade B for Billy? Anybody? You can either unmute or you can type it in the chat. His conditions are managed, his habits with his meds, right? And that was something I read and was like, y'all definitely want to remember that, because is it controlled? So he had the high blood pressure, he had the mood disorder and the anxiety, but those were both clearly controlled with medicine. So now if y'all knew Billy and he came in your operatory, you know, acting crazy, maybe you used your best judgment and was like, he's a grade C because of that. So again, we didn't have that, but that was just a little funny example. But yeah, he's definitely a grade B because it's controlled. But everybody else, we agreed it was generalized, and we agreed on stage 3. Perfect. So now we'll move to our last case study.
Okay, let's talk about Shane. Shane's a 26-year-old musician. He says that his teeth hurt and he doesn't smile because he doesn't like the way his teeth look. He has been hospitalized for GI distress, and he takes prescriptions, an antacid prescription when he can afford it. His last dental visit was 10 years ago after his braces came off. While he was in braces, he was drinking 4 to 5 sodas a day and did not brush his teeth. Let's look at his dental health behaviors now. So he's reports that he's brushing daily, not the fronts because they hurt him due to the sensitivity. He smokes 1 pack of cigarettes a day, and he's still drinking those sodas every day. He has calculus, generalized. Look at his intraoral pictures here. What are you guys seeing there? Looks like a lot of decalcification. No wonder his teeth are sensitive. What else do you see? Some stain, smoking, right? Sodas. And here are his radiographs. Take a good look at those. Okay, here's his perio chart. You know what you have to look for here on the perio chart, right? So we're going to take another poll here. See what you think Shane is. So what is the stage, the grade, and the distribution for Shane? Give you guys just a few, 30 seconds.
Just a few more seconds to lock in your vote.
Okay, so 67% of you said that Shane was a stage 2, grade C, and generalized. And that's what we believe Shane is as well. 26% of you thought he was a grade B. So can you guys chat into to explain why he was a C instead of a B? Or you can unmute and talk.
Yeah, because of cigarettes. We said he smoked a pack a day.
Excellent. Great job, everybody.
Yeah, honestly, y'all were really impressive. Y'all got a lot of these very accurate. So we just have a few more closing slides. We're at the end of the case studies. We're going to close it out and wrap this up for you. So these are the frequently asked questions for the update, and this is straight off the AAP website. So a lot of the things we have on here are right off the website. So I definitely urge you to go on, explore. They have a lot of great learning tools for us. But we got asked a lot of questions when we first started presenting this course, and a lot of these were on the FAQs on their website. So I pulled them off and added them to the presentation. So The first question, which somebody asked something similar to this earlier, is how does this new disease construct impact what I submit for insurance? And the answer is it doesn't affect anything that we're doing differently when it comes on the insurance side. They reimburse us based on what we submit to them. So we need to make sure we have those clinically excellent radiographs, that complete full perio chart. So clinical attachment loss is really evident. And hopefully we have great notes along with that, and the stage, the grade, and the distribution is listed in those notes. And, hopefully insurance will say, have no reason to balk on reimbursing us for that. We all know how insurance can be. What I do want to say, I think most of you are Aspen hygienists on here. So our EPMS system is going to be updating where we have to pick a stage and grade and distribution for every single perio patient. But until that, I actually urge you to add it into your notes template. So it will remind you until it becomes second nature to have the stage, the grade, and the distribution for any perio patient. A couple other things that I definitely want to make sure y'all know, again, this is straight off their website, is what is meant by the consensus statement, a periodontist patient is a periodontist patient for life. And this is another big change that happened in this update. And what it's saying is once they have perio, they always have to be perio. And they're saying if they've had perio in the past, they never should be treated like somebody who's never had perio. And again, I think this is aligned with the medical community, right? So a patient who has had cancer isn't treated like a patient who's never had cancer, right? They have more frequent office visits. They have to go more frequent checkups. I know personally, I have to go every 6 months because I've had skin cancer before. So now I have more frequent checkups than I did before. So why would we treat our patients any differently? So every perio patient is a perio patient for life. Now, if they're perio maintenance and they're having those, excellent home care and their pockets are as tight can be, you can extend out their recall length, meaning they can go to 6 months, but still they're going to be in PMT. They cannot be a prophy. That's a big change there. If you're an oldie like me and went on, definitely learned, we used to put them on prophies all the time if they had great checkups for a long time. So the next frequently asked question is, can I use a stage for each quadrant or sextant like I did with the past classification system? The answer is no. It's a one size fits all, for that patient, for their whole mouth. So that means you only stage from that worst site of clinical attachment loss, and that's what it is. That's all you're looking at when it comes to staging and grading your patient. Any questions about anything we covered? We're happy to answer them for you. Does anybody have any questions? Nope, everybody good? So Aileen and I are going to stay on. So as you're taking the course evaluation, please definitely, we're happy to answer your questions. If you want that print off the AAP website that has the staging and grading, if for some reason you don't have that, I think it's on our hygiene resources page as well. I know it is actually under, I forget the subcategory it's on, but I can also email it to you. My email's on the screen. Aileen's is on the screen. I know all your hygiene managers and directors would be happy to help you as well. But if you need that, definitely just shoot us an email. But this is your course evaluation. You open up the camera on your phone and you just hover over it. You don't have to press anything and the survey will pop up. This is how you get your CE certificate. So you definitely want to pick up the phone and scan this QR code. It'll take max 2 minutes for you to fill out. But definitely this is how you'll get your CE certificate. They ask for the course evaluation.
Thanks for all the great feedback.
Thank you.
So
Again,
how would I do that if I'm on my phone for this meeting?
do you have somebody else?
Take a screenshot. Just take a screenshot.
Screenshot works?
Nice. Take a screenshot. Good. I just learned.
Good idea.
I just used someone else's phone near me at another one and it worked. So. And again, this is just a reminder that your CE certificate will be sent to you within 60 days of today. If for some reason you don't get it or you need it sooner, email cde@aspendental.com. But Aileen and I want to thank y'all all for joining us. We really enjoyed it. Y'all were amazing at answering all those clinical case studies, and we really appreciate it. But if y'all have any questions, just let us know.
Thank you very much.
Thank you,
Yeah,
everybody.
thank you.
Thanks, Cam. Thanks, Aileen. Great
You're
content.
welcome.
Thank you. Once you complete the course, you are good to go. I hope y'all have an amazing weekend, and we have about 30 people left on, just completing their course evaluation. Yes, you definitely need to do the survey. Absolutely. The course evaluation. Perfect. You're great. And y'all are good to go. Y'all have an amazing day.
Have a great weekend.
If your Savari is not responding, I'm sure you're fine. I wouldn't worry about it. You'll still get your CE. Thank you, Randy. I appreciate that.
Thank you.
I hope Florida's having nice weather, unlike here where it's 30-something degrees.
Gosh, I think we're like at 60 here.
Norma, if it's not responding, don't worry about it. You'll still get your CE. Oh, happy Thanksgiving. I forget Thanksgiving is next week.
Happy Thanksgiving, Katrina.
Nice. I already got Christmas stuff at my house, so I'm a little ridiculous. But I love Thanksgiving too. Awesome.
Is this course going to be available again at some point?
You know, it's a good question. I don't know. I'm sure Caitlin can definitely, organize one for y'all, do one herself, something like that for sure.
Okay, thanks.
Yeah, no problem.
Yeah, I'll keep you posted, Kelly.
Thank you.
I mean, if you can't open it, don't stress over it. You'll still get your CE. We'll make sure of it. We have about 14 people left. Hey, we even got done about 10 minutes early, see?
Mistakes. Ahead of schedule.
Caitlin, is there anything you need for us? Are you good?
No, I'm good. Is there anything I can help y'all with before signing off here?
No, I'll wrap up with Patrick next week and making sure that he'll let you know who all is going to get the CE and have a list of participants and all that good things for you.
Perfect.
As far as perio for life, what if you feel a patient was overdiagnosed? If they don't have radiographic bone loss, I would do what you feel is right for sure. I think that goes with your best clinical judgment. So if there's no bone loss, I wouldn't put them on perio. They can if you feel like it's best. That's when I would just use your notes and your documentation to back you up with that. And insurance will pay a prophy over perio any day. Casey, don't stress about it. You'll still about not opening the survey. You'll still be able to get it. Oh, you're welcome. We're just gonna give it about 1 more minute and then we'll probably sign off here. All right, everybody. Everybody have a great, fabulous weekend. I hope you have beautiful weather and a happy Thanksgiving.
Happy Thanksgiving.
Figure out.